Good evening, all. Welcome to ICMR and IISC's webinar series on implementation research. I'm Dr. Kavita Dhanasekaran, scientist from ICMR headquarters. So today our session will be on the stakeholder engagement and contextual adaptation. First, we will have a didactics lecture by Dr. Pragati Hebbar. Dr. Pragati is a dentist by training, and she has more than a decade of experience in public health research, and she's a trainer in the implementation research, and she has published well in both international and national journals. And Dr. Pragati has given us a recording for today, so we will start with the recording, and later we will have discussion with Dr. Pragati, Dr. Vishwajeet Kumar. Dr. Vishwajeet sir is a renowned implementation researcher. We all know, we heard about one of his projects in the form of case studies before, the kangaroo mother care project, and he has a lot of experience in implementation research. He's also a trainer. So we are very happy to have our experts here today, and welcome both of our experts, Dr. Pragati and Dr. Vishwajeet sir. So after the lecture and the discussion will be led by Dr. Vishwajeet, Dr. Pragati, along with Dr. Sumit Agarwal from ICMR headquarters, and also with Dr. Prabdeep Kaur from Indian Institute of Science. Without any further ado, we will like to start the didactics, and we request all the participants to ask their queries in the Q&A or in the chat, so that we can engage experts in the discussion in the later parts. Thank you so much for joining us today. So please, can we have the video now? So before the video gets played on, if Dr. Pragati wants to, give some introduction or, something to start with, that would be fine.
Sure. Thank you. Thank you, Dr. Kavita. And hello, everyone. It's a pleasure to join you all today in this 5th episode, along with Dr. Vishwajeet Kumar. So today's main aim is to touch upon two topics, and both of these we've found a common thread across the past 4 lectures so far, which is of coordination and working across multiple stakeholders. So in today's session, we try to touch upon that, explaining how stakeholder engagement is a very crucial link for conducting IR, and also looking at it through an example of one of the studies that we had undertaken. And beyond this, there is also the context and contextual adaptation that we'll be speaking about. So in that, again, I think, as we all know, a lot of our theories and explanations come from many foreign countries, and it's sometimes not directly fitting into our setting. So it is crucial to understand which components we can adapt to our settings and which we cannot. And context itself is seen differently in different types of research. For example, in realist research, context has a slightly differing meaning, whereas in many other forms of research, context is more like the background or the geographic setting where we are working. So to understand that in detail and explain that to your research audience is important. So Dr. Kavita, you can let me know in case there's any issue with the video, then maybe I can go live. Otherwise, yeah, if the video can be pulled up, we can go.
Let's try playing the video. Yeah.
Sure. I think it's not audible, so maybe the video has come
Just
up.
Yes. I think
just
just the
give
mic,
one
I think.
second.
Yeah, yeah, yeah.
He's trying
Please
to
take your
fix it.
time. Take your time. I'm sure we all understand this.
Solomon sir, can you try playing the video again? We were not able to hear the audio. We are not able to hear, sir. So there is no audio.
One minute.
Just give us few minutes. I'm so sorry for the glitch.
Yeah,
We
yeah.
had tried.
No,
We
no.
had tried playing it before it worked well before the session started. Just give us few minutes.
Yeah, yeah, yeah.
So
Please,
sorry
please.
for this.
Not at all. I think we all understand. So this is just part of. Thank you so much for the team in the background trying to make this work. We completely understand and appreciate what you're doing.
Hello, everyone. It's a pleasure to be with you all here today in the fifth episode of the Implementation Research Explained series by ICMR and IISE. And I'm also pleased to be joined by Dr. Vishwajeet Kumar to take you through this session. So today, I'll be mainly focusing on stakeholder engagement and contextual adaptation. Before we dive into today's topic, I would like to do a quick recap of the journey that has been covered so far. We started with an excellent overview of IR, especially from the Indian perspective by Dr. Bahal, where he shared on the importance of and the need in our current context in India of conducting good quality and robust IR studies. In the next episode, we heard Dr. Ashu Grover showing us all the different programs on IR that are run by ICMR. And further, she also explained how the role of the IR researcher is. It's more of a facilitatory role and ensuring that existing health programs are improved and strengthened and work in a better manner. In the next episode, we heard from Dr. Aarti Kumar, mainly on case studies on implementation research. And through this session, we wonderfully saw the entire life cycle of an IR project. What is all the prep work that goes into it? How does an IR project look in planning and execution and in the stage of follow up? She shared several interesting nuggets of information. And in the fourth episode by Dr. Prabdeep Kaur, we saw how it is important to frame appropriate research questions and objectives for our IR study. The main reason being that the question decides the entire flow of the study. It decides how we choose our methods, how we conduct data collection, analysis, and the entire course of the study. So today, Dr. Vishwajeet Kumar and I will be mainly focusing on stakeholder engagement and contextual adaptation. So with that, let me start today's session. When we mention the word context, what does it mean to you? To take a moment to think and reflect. All of you might be conducting a variety of studies, especially those who are conducting IR studies, definitely need to understand the importance of context. But even in other forms of research, it is crucial to know the context in which we are engaging. Some of the main headings that come to mind and need to be considered when we study the context of a problem include things like the socio-economic context. So, what is the level of education, the kind of residence, the demography of the people that you plan to work with? What are the cultural contextual factors? So, this can be, are there any particular beliefs within the society that you're working in? Any ethnic identities, any particular traditions that they follow, which may or may not hinder or facilitate your IR study. The political context. What is the power relations that exist and the power dynamics? How are the governance structures within that setup? Are there any political affiliations that people go by? And what are the structures in terms of the political economy that exist? It is important to understand these so that the intervention or the study that you design is aligning with this and not in a way at loggerheads with this. Further, depending on the population and the geography that you choose, there could be physical factors, contextual factors, such as the terrains, distances from health facilities, rivers, etc., that might be an obstruction. Especially in hard to reach areas, it is very important to factor all possible costs and other barriers that you might face when you're planning your IR study. Moving on, you could also consider institutional context. So, suppose you need to work once you decide the level at which your IR study is. Is it at a healthcare facility level? Is it at a district level? Is it at a state level? What is the institutional culture there? How do people relate with each other? And what are the attitudes? Because these will shape how your IR study progresses. Is there going to be trust and is there going to be uptake of your study and its findings? Such factors will be determined by the institutional context. The health system context. So we are aware of the health system's building blocks, etc. So these are the kind of things that you need to look at when you're studying the context. So this could include what is the kind of information, health management information available, what does the workforce look like, are there shortages, are they adequately trained and equipped, how is the service delivery. And lastly, another thing to look at is the stakeholders. Are non-governmental organizations, self-help groups, women's groups, schools, etc., adequately engaged? Are they working on your area of study within the selected site or not? Can you build on that rapport that exists among different stakeholders? So these are important questions to consider. Now that we've seen a few things that one needs to keep in mind, I'm sharing an application of a multi-layered context framework. So here, this was a IR study related to cancer. And the different ways in which they looked at it was starting from the individual or family level. So looking at things like affordability, are they able to pay for the treatment? What are the social protection schemes that are available? What are the social embedded norms within the society? And then at the community level, is there adequate social support or not? What are the norms like? And is the community adequately engaged? At the healthcare setting, again, they look at some of the health systems building blocks like facilities, staffing, the organizational culture. Then at the local and district level, they bring in things like governance, leadership and administrative practices, the the physical environment, and lastly, at the national or state level, the socio-political climate, what is the priority that is given for cancer care, and what are the policies that exist for health and social welfare. So this is just to give you an example of how you can apply the context lens to your particular setting. And there are several such templates available for different kind of frameworks that can be used. The reason why you can choose a framework is it just helps you organize your thoughts better. So now once we have done an implementation research studies planning and looked at the context, this particular figure from the same article explains that how are the different ways in which we can assess the context, and then what do we do with that information. So for example, the assessment of context can be done at the formative phase or the planning phases. So how can we do it? We can do it through formal or informal assessments and interactions, engagement with stakeholders. We can also use locally available resources and materials related to the context and any other diverse sources of data. Now that we have all this information on the context, how do we use it? So we can either use it at the time of developing our intervention. How does it help at that stage? It will help us inform and adapt the content of the intervention already. It might even improve the participation if we know what are the preferred ways in which people like to engage. And it can also improve communication with the stakeholders. Suppose we do stakeholder engagement or the contextual mapping at during the implementation process, then how do we use that data? We can use it to improve the provision of services. We can improve and engage the stakeholders better. We can also provide feedback on the gaps that exist, and we can promote institutionalization. So with that, we have seen a little bit on the first topic of context in IR. Now, I'd like to share this maybe a decade-old image to just see what are all the kind of stakeholders and what is this context. So this is actually the enforcement of the Cigarettes and Other Tobacco Products Act in one of the districts in Karnataka. And one of the provisions prohibits direct advertisements of tobacco products. So these kind of boards with the brand name, with backlighting, and without the health warning, etc., were not allowed to be displayed. So in this image, who are all the kind of stakeholders that we can see? So we can see the shopkeeper, we can see the police official, we can see a plainclothes health inspector, we can see general public. And there are also some hidden stakeholders, for example, like the tobacco industry, which can be providing the boards. There can be media, which will pick up this story, and if they publish it, they end up spreading a lot of awareness on the issues. So this was just to bring to your attention the kind of stakeholders. Although this is not an IR, but this is more of an action that is taking place. But just to re-emphasize the fact of understanding the context and the stakeholders involved. So the second segment that we wanted to talk to you today about was stakeholder and community engagement. So how would one go about doing stakeholder engagement? So we would first ask ourselves or within the research team a few questions. Things like, which are the institutions or individuals that are most important to our implementation research study? Why is our study or intervention important for them? Do they need it, or have they asked for it? Have we engaged enough with them? Have we seen the context, and how have we decided that this intervention is required? Then how will we identify such stakeholders? So are there any organizational charts available, or have we done our stakeholder mapping exercise and tried to figure out who all are the stakeholders that we need to engage with? So in some programs and settings, there are already a long list of actors that are listed, that all these different officials need to take part, or different types of civil society organizations, etc. So are such lists available, and how will we identify the stakeholders? And lastly, what will be the role that these stakeholders play in our study? So for each of these, there are different sort of templates and grids available. So for example, even for the roles, we have things like the interest and influence grid, where we can see what is the interest of that particular stakeholder in our topic, how much influence do they wield. So, the power that they have to either support this study or even disrupt the study. We can also, depending on these factors, decide what kind of engagement we want to do with them. So I will come to that in the following slides on what engagement can look like. But now let us talk a little bit about community. So in many, if not all IR studies, we will be in a place where we need to engage with the community. And community can be defined variously. So depending on your topic of study, that can be the definition of the community. So it is important to have the scope and such definitions very clear upfront in your IR study. So as I mentioned, there are different ways of engagement. So the first one being consultation. So we can call all our key community members and we can seek their inputs. This could be through a discussion, this could be through one-on-one consultations. It can also take the shape of a survey if required. Sometimes engagement can also look like education, where if we realize that the level of awareness of our particular topic itself is extremely low, the starting point can be education, where we inform people and spread awareness and start talking and educating them about the issue at hand. And then we can seek their buy-in. Engagement is also seen as communication. So trying to figure out the most accessible and acceptable ways of communicating with the community. This can be very different for different sets of people, depending on their age, their geography, and various other factors. So, in some places, online, social media related communication may be appropriate. In some places, just sitting together, bringing people together in person, in small groups might be appropriate. In some places, it can be large groups that can be brought together. So this is something that the research team needs to carefully assess and take forward. Engagement can also look like participation. So within the actual research itself, so like a medical officer, for example, being one of the co-PIs on the study, or someone from a civil society which has embedded work for several years in that setting. They can also be part of your research study. So having a multi-sectoral team improves the vision and the conduct of the IR study. So this can also be a way of engaging stakeholders. And lastly, it can also mean just complementing each other's work, providing some extension supports, partnerships, and engaging through that process. But one important thing to keep in mind is that this is not a one-off activity, that we take a grid, we keep a list of all the stakeholders and the community at the start, and so So it is something that so it is something that has to happen throughout the IR cycle, and only then it is effective. And the nature and level of engagement can keep differing throughout the different phases of the intervention. There may be the requirement of a very close engagement and interaction in the initial phases, followed by some data collection and other heavier phases by the research team during the intervention phase, and later during the uptake and scale up, there might be again the need to revive engagement and interaction. So these are the kind of decisions that the research team needs to take, but to keep in mind throughout the research project. So what are the reasons that one should engage the community in the IR project? So first and foremost is that it ensures good research ethics. Now, why do we say that? Because the fundamental principles of beneficence, justice, autonomy are upheld. It demonstrates that there is a respect for the community. We are not going in with our own assumptions that, oh, the community needs this, the community needs that, and we have all the solutions. That would definitely not be a very acceptable or sustainable approach. Further, it also integrates the existing community strengths and resources. We may not be aware, but once we engage with them, we might realize that they already have certain resources, certain networks, certain ways of engaging within their community, and that can help strengthen our IR project also. It further also facilitates acceptability of ideas and research approach. So, be it at the initial phase or later, if you want to scale up things, it is very important to have the acceptability of the community. And having this prolonged or long term view of community engagement might help in that. Sometimes it also ensures shared responsibility in the research endeavor. So, like we discussed, that if a medical officer or any important other stakeholders within the setting are part of your research team, it already shares the responsibility with them. It also ensures that there is community ownership of the research. So it's not seen as something that only some researchers have come from somewhere and they want to find out, but the community also feels a sense of ownership and interest within the research. It is also good to create trust and mutual understanding. And one of the most important thing is that it can also empower the community by having them improve their self-esteem, self-reliance, if they are able to understand and engage in the research process. So with that, we have touched upon briefly both the topics that we intended to do today, which was context and contextual adaptation, and community and stakeholder engagement. So now in the next few minutes, I'll take you through one application of a realist evaluation, which used a implementation research approach. And here the focus of the presentation would be on the contextual factors as well as the community or stakeholder engagement. So a little bit of about tobacco issue in India. So almost 28.6% of adults, or 266 million adults, use tobacco in one or the other form. This poses an enormous economic burden of 1.04% of our GDP. And another issue is that the prevalence ranges from as low as 9.7% to as high as 64.5% across Indian states. And similar to the diversity in prevalence, the diversity in implementation is also humongous. So here, based on the Global Adult Tobacco Survey data, we can see that the states in green have improved in their implementation, proxy indicators of implementation. The ones indicated in blue are average, and the ones indicated in peach and red are worsening in implementation between the 2009 and 2016 rounds of the GATS data. So now looking a bit at the policy context or the policy response. Since very early on of 1902 till 1960s, the evidence on tobacco use causing cancer in India has been constantly building up and growing. Finally, in 1975, we had the Cigarettes Act, but it was limited in its scope and implementation. Following which, a decade later in 1986, there was the nod given by the parliamentary committees on initiating a comprehensive legislation for tobacco control. So from here, for the next few years, or rather several years, consultations across the country took place to understand what are the requirements and how does one go about developing a comprehensive legislation. And in 2003, the Cigarettes and Other Tobacco Products Act, or COTPA, called in short, was enacted. At the same time, globally also, there was a lot of movement and traction on tobacco control. The WHO was organizing several interministerial and inter-country consultations, etc. And they came up with the Framework Convention on Tobacco Control. This is an international treaty which is very widely ratified by several countries, and India was one of the early signatories in 2004. And finally, in 2007-8, the National Tobacco Control Program, or NTCP, was launched. So now, to give you a bit on the content of what is COTPA and what is NTCP. So in COTPA, there are several provisions, but the four main enforceable ones are of prohibiting smoking in public places, prohibiting direct and indirect advertisements like these, ensuring that there is no sale of tobacco products within 100 yards of educational institutes, and mandating pictorial health warnings on tobacco packages. Now, what did the NTCP do? The NTCP gave this entire effort a structure. So it made it into a three-tiered structure, which was the National Tobacco Control Cell, State Cell, and the District Cell. And it also gave the program resources in terms of finances as well as human resources, that what kind of people will be posted at each of these levels, and clarity on their roles and responsibilities. So in our IR study, what we did was we chose three contrasting Indian states of Kerala, West Bengal, and Arunachal Pradesh, and we conducted 48 in-depth interviews and 106 non-participant observations and 8 focus group discussions. So for us, the stakeholders, the key ones, or the community, was the policy makers and policy enforcers or implementers. So to give you a bit of an understanding of the settings that we looked at, things like the ease of accessibility of tobacco products, its usage, violations that happen, kind of advertising that is taking place, the restriction to minors, those sort of clauses, and the advertising clauses. So most of our data collection revolved around the program components. Now, since we had conducted a systematic review of literature before starting, and then we undertook 48 interviews, but only in 3 states, we wanted to test and validate these findings that were coming from the 3 states across further several states, because in India, state by state, district by district, the context keeps varying. So we held 2 regional consultations. One was online during the COVID phase, and the second was in person. And through these 2 consultations, we engaged with 55 stakeholders. These were mainly implementers, so people from the education department, health department, police department, the academia, as well as civil society who are engaged in tobacco control. And the intent for these consultations, like I mentioned, was to validate our findings. So, this being a realist evaluation, in which we start with the theory and then we end with the theory. And mainly, our lens of analyzing data is to look at the context, the mechanism, and the outcome, the CMO configurations. So for us, the main intervention under study was Cigarettes and Other Tobacco Products Act and the National Tobacco Control Program. In the context, there were several facilitators, like where there was active institutions, infrastructure was in place, there was a good rapport among civil society, the police, health, and other sort of stakeholders, where in several states where the civil society was very active and they were also active on other campaigns, for example, drug control or other youth campaigns, etc. And there were trained human resources. Some of the barriers included states with very high prevalence, where there was also a very high level of social acceptance, easy accessibility of tobacco products at every nook and corner, and also where there was limited civil society engagement, and but there was a high amount of tobacco industry interference. So, how do different mechanisms work for different stakeholders? So, for civil society organization, the thing that worked was collective action, where they were respected and engaged in the process in states uh, throughout, from the policy consultations till the enforcement implementation. There was a very smooth coordination across health department and other agencies. For law enforcers, if they did not feel an accountability to the system or to the higher ups, or there was a lack of monitoring, there was very sporadic enforcement efforts happening. In places where they felt accountable to undertake such activities, there was more action. For public, the main mechanism was of fear. In states where they could visibly see a lot of enforcement happening, people being fined, and the enforcement like the removal of boards, etc., the vendors and the public both were complying much better. Whereas in states where there was very minimal enforcement activity, it was not visible to the public, there was high non-compliance. And for the policy makers, tobacco control was an issue of prioritization. The moment they were able to prioritize it for different reasons, maybe high level of use or high violations, they were able to pool resources better across different buckets of funding, and they also monitored the program better. But in states where for different reasons it was not a priority, where there were other pressing issues, they were unable to move much on implementation. So we shared the findings of this study at the end with a third consultation, which we called as the national consultation with the health minister of Karnataka and also several other state officials. So these are some glimpses from there. And what were the kind of outputs that we developed as part of this implementation research. So it included policy briefs where succinctly we had the key findings for what they were looking for. We also shared such data collection images to make it a bit more relatable and understandable. We developed a comic book which spoke on these main themes of fear, of advertising, and other themes that we found within our data. And we also came up with a documentary, a short film that explained the entire issue of tobacco control and was screened in the presence of all these 55 stakeholders across the country. And it was also found to be relevant as a training material that many of them can uptake. This consultation and conclusion of the study also garnered a lot of media attention. Thereby, it helped the state officials to further refocus on tobacco control. Other outputs, and I'm sharing mainly from the perspective of engaging stakeholders throughout the process, included inside implementation webinar series, where right from police officers to headmasters of schools to local level implementers, researchers, academia, we used to create a space, and we've conducted 9 such episodes to dialogue on challenges and successes related to tobacco control implementation. Further, the typical conferences where we were able to share and disseminate the learnings. Workshops, so capacity building was also an angle that we wanted to focus on. So we did realist related workshops so that the methodology is also understood and used by many more. The 2 consultations that I mentioned. So in total, with all the 3 consultations, we were able to engage more than 90 policymakers and implementers throughout this study. And finally, as the study topic is relevant to schools, colleges, and other spaces, so whenever there were invited talk opportunities at different universities or events, public events, media, the research team always engaged and responded in a timely manner. And the typical implementation research and the scientific outputs of papers and courses were also undertaken. So with this brief example, I'd like to sort of wrap up and summarize that context is extremely crucial, as you would have seen, in the lens of IR, mainly because it helps us understand and frame the study in a way that it can be sustainable and it can be helpful to the community and adds valuable knowledge to the missing gap within the scientific literature. We really cannot conduct parachute sort of research, especially in the IR domain, where we just come into a new setting for a short period of time and attempt some strategies based just on literature or some other settings. So it is extremely important that we understand the context in detail. Stakeholders are important because if you want to conduct the study, as well as if you want to think of scaling up or even just sustaining interventions, these local stakeholders are the ones who can make or break that decision. Community is most important. So identify your target community and try to understand them better. And like we saw, it is not a one-time engagement either at the start or at the end by conducting just a dissemination sort of a workshop or sharing something in the media. It is a process that needs to be done meaningfully throughout the course of the IR study. With that, I'd like to thank you all for your patient hearing and hand over to Dr. Vishwajeet Kumar. Thank you.
Oh, thank you so much. I won't say everything, but all that I'll say, you are so grateful, so thankful that, despite, there are many reasons that you wouldn't have been able to do this webinar, and yet you took the effort, extraordinary effort to actually record it. And more importantly, again, today was not a day that you should have been here, but I think you have again made the effort. And so we, on behalf of everyone here attending this webinar, we remain very grateful. And so, this has been, for me personally, this has been very educative. So, Dr. Kavita introduced me as an expert. I do not consider myself as one, but I do consider myself as a very keen and avid student of implementation research. And therefore, as a student, I think it was listening to an amazing teacher. And thank you, Dr. Pragati. I just wanted to, kickstart this and, because we also wanted to hear you, both your recording, but since you're here, we just wanted to take advantage. But before I go there, I'd also like to welcome Dr. Pragati. I think I saw her briefly, and I think she's there, and I would request her to make her welcome. So, in fact, I owe it to you because in the last session, you actually made the modification to make it conversational. And I thought I should just take it forward and, and acknowledge that, what a beautiful idea it was. Thank you, Dr. Pragati, for coming, and we'll be on that. So, Dr. Pragati, thank you so much. I just wanted to, just as a curious student and some practitioner of this, how much is this science and how much is this art? Just from your personal experience, because I was just curious. And
Thank you, Dr. Vishwajeet. I think very sort of interesting question to start off with. Yes, I think there's a lot of science to it because many fields beyond implementation also, right from say the business field, the marketing, etc. They have a lot of literature on how to look at stakeholders from their lenses. So depending on the kind of stakeholders we have, there is a lot of science backed on how we can engage with them. But the doing part of it in an IR study is a lot of art, especially for the researchers to pick up those skills because it's not very typical classroom sort of settings where you can be told that this is how you'll approach and this is how it will go. These are real world settings, real people that we're dealing with, people with unpredictable schedules, unpredictable sort of even attitudes and positionalities which can change over time. So it is definitely a mix of both, I would say. Yeah, thank you.
Okay, yeah, thank you so much. I'm also, I want to take advantage of Dr. Pradeep there as well, and I'd love to hear your take on the same question. And the reason, Dr. Pradeep, that I ask is, Pragati, you started with the context, and here I think there is a context to this webinar as well, right?
Yes.
Thanks to ICMR and its leadership and the need for the country, that we believe that we know what works, how do we make it work? And I think part of the reason for this webinar and many other things planned in this series is actually to help create an environment, an enabling environment, as well as a whole community of practice of researchers, and build this field as well in implementation research. And one of the key, almost universally in almost every workshop that I have attended or been part or facilitated, sometimes implementation research can become very overwhelming. Probably the least overwhelming is, it's also at the research question level. But I think the more you keep moving beyond the research question after you have framed it, and particularly when it comes to whole idea of context, mapping, adaptation, stakeholder engagement, participation, these almost become territories that many hardcore clinical researchers find it a little difficult. And Dr. Pradeep, you have done both of that. So I just wanted to hear some of your just experience, perspective in a very informal way.
Yeah, no, I completely agree with you. My initial years, I was doing more of epidemiological research, very classical like surveys and things like that. And I think when I made my initial transition to implementation research, I didn't know it was implementation research, let me be honest, because this term came very recently. This term did not exist actually when I started doing this. Later on, I realized that's what I was doing. So, but the point is that when I started working on interventions, let me say when I started working on interventions in programmatic setting, because that was my way of looking at it, uh, I felt I did not have the right skills actually. Because my sort of research methodology knowledge told me what need to be done, as you rightly said, but then the stakeholders had many different perspectives, and I was not prepared to answer their questions, and I was also not prepared to address their concerns, which sometimes were genuine and sometimes were some assumptions which they have made, but it was from their point of view they were right. So, so in my opinion, to answer your question that, how much of it is science, I think knowing what need to be done is important for an implementation researcher. You really need to have your grounding in the science. You need to know the evidence because implementation only comes when evidence is already there. Once you have that knowledge, then comes the need for additional skills, which actually can be consciously acquired. Again, I won't say, sometimes when we say art, people get this feeling like you should have inherited it or something like that. So I don't want people to think that. It is something which can be acquired with experience and some little bit of mentoring. I feel more than training, mentoring is important. And I think I learned the most like when I did meetings with some of my senior colleagues. I had a senior colleague who will say, "I'm going to go meet this official. Just come with me," right? And it sometimes I felt scared to enter office of a senior officer. I'm sure many doctors feel that it can be intimidating. But then I would just sit and listen how they're talking, how they're building the conversation. And especially when you go to field and it's not your home ground, you're not familiar with people there, you don't know anybody there, and suddenly you have to go and meet, let's say, a district official or any level official. So I think a lot can be learned by observing others, by mentoring, and also you can draw a lot from your own experiences over a period of time. But in the initial years, it can be challenging. And the last point I want to make is there's something which you can actually do like a background homework for these meetings, which helps a lot, which I mean, I learned later on. If you can write down the kind of people you are meeting and what their expectations are. For instance, like, let's say if you're meeting a secretary, they are going to be thinking more about scalability, practical issues, and taking something to the program. If you're meeting community leaders, they'll be asking you, how is it going to help my village? If you are meeting a district, let's say a CMO or the program officer, they are more worried, will it increase my burden? Will it put more, sort of burden on my staff? So you can actually write down what will be the concerns or expectations and your answer to that. So you can do bit of homework. Everything you need not do extempore, but there will be new surprises which you will have in your meetings. And if you cannot handle it in that go, the way I have done it in past, and I feel this is a practical way to do it, is you request for another meeting and you say that, okay, I understand these are your concerns, and let me go back, let me talk to my colleagues, or let me talk and understand how we can address this and go back. So don't close the door. Sometimes I feel you end up in a meeting and it's like make or break, right? That's very hard for people from medical background. So go back and do a reflection on it, discuss with your colleagues and your seniors and see, okay, do you think we should be doing it or not doing it, or how we should be doing it? And I think these are things, and you get better at it over time, like when to say yes, when to say no, when to say okay, maybe I'll come back, and so on. But keep the doors open. I think if you ask me one message which I learned from my mentors, they said, never burn the bridges with your stakeholders. Never burn the bridges. Even if it makes you angry, even if it makes you upset, you will have to go back to same people again. So hold back, come back, and reorganize yourself and go back again. Thank you.
Thank you so much, Dr. Pragati. This is profound. I was just thinking that this whole community of that we are all participating in this webinar. Just that unfortunately the context is that we cannot have everyone online and contribute, but I'm sure we will have someday. But at least this technology doesn't, at least in the time that we have, doesn't enable. But what an amazing learning this is. This is very profound. This is very profound, very hard to find in any book of implementation research. I was just recently, a couple of weeks back, I was on a morning walk and I was traveling, and I met this stranger. The stranger happened to be just a marathoner who had participated in almost all major marathons in the world. And I just love to talk to people and listen to them. So I started talking to him, and he just happened to be in one of the corporates in big honcho. And he was in sales. So I just asked him, we work with governments, and sometimes it can be very difficult for us to go and wait. And, it's sometimes it can be very demeaning, And so I said, but sales is all about how do you do it, right? He said, for us, there are two rules. One, you begin with whoever you go to meet. It could be a shopkeeper, it could be your, agent or dealer, or it could be the chief secretary of that state. Whoever it is, you need to meet them where they are, number one. And number two, they said, never take, when they say no, don't take it to your heart. They don't necessarily mean it. If you actually go back, reflect, come back, and try again, it is possible that that no would have translated into yes. You never know. There's so many reasons to do. So, this is, and I wish I had this, somebody would have shared this to me, because me too, it's uncanny that, my journey to, and therefore I say, I am not an expert. I'm still a clinical trialist. I still do a lot of, clinical trials. And I was just wondering before this, before this webinar, why is stakeholder engagement so difficult? Why does it appear so alien? And so this is also part of my, other discussions that we have in ICMR. And there are some of my theories. Okay. One of them is just as when you're a clinical trialist or a clinical researcher, you are God, right? You have so much of control. Everything about clinical research is to answer this question, what works in that controlled condition? Everything is controlled for, except the intervention, right? And therefore, and you go to large lengths to make it happen, whether it's in the form of randomized controlled trials, then you single blind them, you double blind them, you do everything to make sure that it's, you have reduced the human in there, made it as objective as possible. And there your stakeholders, in this case, the most important stakeholder would be the participants. It's very recent that they were actually called participants. When I started, they used to be called as subjects. And when I started researching on this, and I realized, oh, the Britishers used to call us their subjects, right? And then when you go back, then you realize, oh, this is actually also, and I think, Dr. Pragati alluded to this as well. I think it's also the mental model that we have grown up with. There is this, of course, this bit of the research that it has to be objective, and I need to be completely, everything else that comes is a contamination and I need to control it. So I would love to do it in a rat model, but I cannot I have to go beyond. So I need humans, and then it keeps becoming more complex. The second, of course, I believe that there is also, I would say, I don't mind saying that there is also, it's very colonial as well. I think we have inherited a lot of those through our sciences, that someone, this whole expert orientedness, right? So it's very expert centric. I am the wise guy, and I'm going to tell everyone else what to do. And so where, there is literally very limited scope for me to listen to. So I take the data, analyze, publish it, and I believe that it should work. While when you go to implementation research, you realize that, oh, you just need a major shift. It is no more about I, it's all about we. We need to work together. Every stakeholder is a co-creator of it. It's a beautiful system. And that's the reality. And that reality, you can see that as a barrier, or you could see that as a facilitator. And I think as implementation researcher, you're also that engineer who can actually understand the process and the system, how it works, and then be able to tune it. So no, this is I just wanted to share, one key when you mentioned about, when you listen to, I always, that's one of my things to-do list is if I had to draw a avatar of an implementation researcher, how would that avatar look like? One thing is what I heard is that that avatar needs to have a very big ears. It's almost like, I feel it looks like Lord Ganesha actually, right? Big ears, a long nose, they need to be, and they need to have a very small mouth so that, they need to listen more and speak less. I just wanted to go over to Sumit and I'll briefly introduce him. Dr. Sumit Agarwal is a scientist and a program officer at the Indian Council of Medical Research. Is one of the brightest stars in the ICMR system. And he does leads the pioneering work on drones, and you must have read it in the newspapers or in publications. He is published widely. And the reason I invited him and I wanted to hear him was because, just listening to the, trying to introduce drones, whether it is for transportation in difficult hilly terrains in the Northeast or even its organ transplantation, when I was listening and just part of those committees, I realized that context is absolutely king. And I just wanted to hear, Sumit, if you could just, in a very informal way, just share some of your, just the context, in which iDrones, which drones was introduced, and how have you been navigating it? I think that would be extremely informative for all of us.
Thank you, sir, for inviting me. First of all, this, how we started was not like, as you said, it will start with no. So when we thought of delivering vaccine by drones, it was started like a no, because we thought about the delivering vaccine in December 2020, and that time there was no vaccine and no drones. So we started how we will do it. It is very difficult. So we started with no. But as we are talking about lots of stakeholders, but we planned, like, there are stakeholders at the central level, there are stakeholders at the policy level, because when we were talking about the delivering of vaccine by drones, there was no drone policy. That was impossible work, which was never happened in India before. So we were venturing into an area which we were not aware where we were entering. So we try to map out, as ma'am also, Pragati ma'am also show a context, layered context, where we were trying to identify stakeholders from the Ministry of Home Affairs, Ministry of Civil Aviation, Ministry of State authorities, and then we reached to district headquarters, and then ultimately we reached to the community part. So then I realized there are so many stakeholders, which we can say hidden stakeholders. So this is a kind of different term, hidden stakeholders. So even we were not aware what is a hidden stakeholder. So I will tell you a small story. We took all the approvals, all the necessary things. We were with health authorities, and we were in Manipur. Area named is Bishnupur. Bishnupur is a district where nowadays you can hear about lots of activities, activist and terroristic activities is going on. So we were trying to calibrating our drone, and we took all kinds of approval, and we were flying our drones in that area. And all of a sudden we realized we are surrounded by a gun people, and there were 4 or 5 gypsies, those who were surrounding us with the guns, and they were all in army dress. And then we realized we are doing something which we should not do here. And then eventually the few of the people, those who were speaking in local language, then I realized they are speaking in Marathi. Then we started conversation, and I can speak a little bit. So I had started conversation, and after a conversation of, they took all our things, drones and everything, vaccines, those who were having, and they took it to the headquarter. And then we realized actually that was a secured zone, and they are the owner, or they are the controller of that area, but we were not aware about it. Like, they were also a part of stakeholders. So then we showed them all everything, and then for that, after whatever we did in Manipur, they were all very helping to us. So whenever we talk about the stakeholders, there are many things which you cannot list down sitting in your room unless you go to the field. So once you reach there, we faced different difficulties, and then we realized, okay, there are some people, like religious people, we met there. There are youth groups, because in Nagaland, we were in Nagaland, so you cannot enter in a village, or if you are entering, you cannot do anything, you cannot talk to people easily, because there are youth groups and community groups. So they will decide what their village will do, what their community will allow. So first you have to involve them. So there are many small things which we were facing, kind of. So one more thing I would like to add, like when we were delivering first vaccine delivery, Vishnupur to Karang. Karang is basically a beautiful island between the Loktak Lake. Loktak Lake is a biggest lake, sweetwater lake in Manipur. So there is in between of the lake, there is a small island named Karang. So Karang is the place where we were not able to deliver the vaccine, because it is only connected by a boat, and during time of COVID, it was not connected by the boat. So when we try to connect that people, so they were very apprehensive. Then we said, okay, we want to deliver vaccine by drone. So they were already afraid of the vaccine and COVID. And then we were talking about the drones, which were very new things to them. So then we realized, like, we should be aware about the social structure of that community. So we should have that sense. What is the structure? Like, again, you will never read these things into the textbook. What is the local context, social context, or community structure of their local? Then we realized there are some Mizo and Nagas youth groups. So we started conversation them. We had multiple conversation meeting with them, and eventually we involved them in the process of implementing this thing. And then actually I learned what is community participation. We always talk about it should be community participation, it will build trust. As ma'am were explaining, it will build trust, they will have sense of ownership. Then I realized slowly, when they started moving all the activities, they were involved in the activities, and they were doing it by own, and we were just become tangential. So they were doing it everything. So there are small parts which we don't know, and so I feel stakeholders involvement is the key when you talk about the community and the implementation research in the community. Over to you, sir.
Awesome. This is extremely helpful, and I agree that, that trust is like the magical key. I think without that, and it's almost extremely difficult, because we need to recognize, right? It's theirs, and therefore it's important for us that we are able to. Our actions need to be such, and the way we look at them. I believe it's very important how we see them, how we view them, and that's important because then it starts shaping our actions as well. And I think that alignment is extremely important. I just recall a meeting. Still you'll find a lot of international development projects. There is a sense of skepticism, or even sometimes suspicion, etc. And so I was in a meeting with the Secretary of Health, and that was the time where we had irrefutable evidence on kangaroo mother care, but a whole host of other interventions. But this was more around kangaroo mother care. And we wanted to do an implementation research. And the goal was very ambitious. It was, and the Director General has talked about it in multiple forums that you have to achieve 80% adoption and adherence for at least greater than 8 hours across the continuum of care. So right from birth to home, right up there till they are, during the neonatal period. This had never been tried before. Not even attempted in a place like Colombia where it originated. And so it was very hard, and this was to be done by the system. So how do you get them? And so in my conversation, I just happened to ask, I said, what is, what is something that most frustrates you, And he said, when I go to Delhi and where you have our, I believe it's a quarterly review meeting, and where they present the statistics and my status at the bottom of it, it's very embarrassing. It's very, very embarrassing for me. And so, I said, how about, I don't know if we can actually, one of the best and the most effective way, not easy, but effective would be if we actually were to implement kangaroo mother care. And he said, I said, I don't know about mortality. It's not going to come so easily, but at least I can assure you that this is one thing that will put you at the top of the table. And that was, all that I wanted to say that, and I think Dr. Prabdeep was mentioning, that's where you align, right? You're in together. There is another conversation that we've been having for all our national health, priority projects. And the Director General in particular has been driving it. Throughout my academic career, we've always done cost effectiveness. And I'm sure most of you, as part of this webinar would have done the same thing. But then if you talk to the secretary, he's not interested in the cost effectiveness. All that he's interested in, tell me how much more it will cost, right? And so it's so important that we are able to be the translator, be the adapter. And I think that's so, key. Let me just go back to Dr. Prabdeep. I think most of you know, but she was the PI of the Indian Hypertension Control Initiative that very recently got a national award, and we are so proud of the work. And I just, this is what a massive, I'm not aware of many such large scale implementation research. It's just audacious, and I just wanted to, if you could take us behind the scene, right? Now we just read your and the awards and the changes and the shifts in policy. But I'm sure when you were starting, it was almost inconceivable that you could have such better hypertension control in a primary care facility than a secondary setting, right? It's inconceivable. And we are not talking of a time where, where NCD was very much on the radar. So could you just take us back there? I just want to help every one of us understand that, just behind the scene and particularly in the context of stakeholder engagement in the context. Over to you, please.
Yeah, thank you. I will try to say this in 5 minutes. I know not much time. The one thing is that it's 6-year-old project, but it's built on 15 years of work. So it's really not 6 years. That's the first thing. I mean, traditionally, there was a lot of, what can I say, concerns, or the most stakeholders actually did not agree to treat hypertension even in the primary health centers, forget about health wellness centers. So for several years, we worked with the governments which were more receptive. Like, I will not go into detail, but my initial work was more in Tamil Nadu because that's more, but it was a state which was actually trying to embed NCD program in the primary healthcare system. And it took 6 years there to actually take this idea to the ground and to make it work. We did several pilot after pilots. And it was not easy to convince the doctors as well as the other stakeholders that doctors in primary care can actually treat hypertension. I know it always sounds very strange to you, But it was not very long ago that there were concerns that the hypertension should only be treated by MD physicians at the district hospital or the medical colleges. And I would say that those of us who believed in it have had to really like it's been a lifetime kind of a thing effort. But over time, as the recognition of NCDs as a problem increased, we found that there was a little bit more acceptance of at least taking the treatment to primary health centers. So again, talking about stakeholder engagement, it required engaging with the variety of stakeholders, which includes experts, physicians, cardiologists, because they are the ones who think like it's initially had this thing, it's a very specialized disease, and then they realize that medical colleges are getting crowded and district hospitals crowded. They can't deal with the numbers, right? That's when they actually became more accepting and receptive to these ideas. And then also governments want whether you can spend, because we'll go and tell, like for example, in a state they have procured 50,000 amlodipine, and we tell them that for one district alone you need 5 crores. So they're like, no, this cannot be true, right? But then it's actually true, because you've just not been procuring enough because you didn't realize that there were so many patients. And so that I think there was huge gap between the understanding of stakeholders and the need which was there to be met. And then we had to engage with the acceptance from the patient side. So, that was a huge factor as well, because patients think that if you go to a big doctor, you get a better treatment. But it's exactly the opposite. We have seen blood pressure control is better when you go to a nurse or to like a primary health center, right? So stakeholder engagement has been a huge challenge, and we had to work for years and years to take it to primary healthcare level, and repeatedly document better outcomes and a lot of data, but not just data, but also experiences that people actually saw that okay, things are getting better. And then over a period of time, when we embarked on a more national level, like, under India Hypertension Control, we found a lot of difference in different states, how they responded to the idea. And some were a little more confident, and the others were still like, no, we are not sure whether our primary healthcare system will be able to absorb it. So there was a lot of apprehensions, and we had to do a lot of hand holding, sometime go back again and again and again. But what we learned in the process was that being consistent and showing success at smaller level was really helpful to sort of build that environment. But one thing I want to tell you, like, in India, if you can do it in 10, 12 states, then it gets easier. Like, then people are like, okay, it worked here, it worked there. So maybe it should work for us. So in fact, the ones who did not come on board initially, later on, when we went back to the same state, they were like, okay, like, now we feel more confident about it. So I must say that it did get easier very much later. But in spite of all of this, we had a lot of difficulty in decentralizing the care for hypertension to health wellness centers, because again, there was issue of like, how can nurse give, whether she should dispense, whether she should refill, what is the prescription issues, and it's not yet resolved in all states. But the only good thing that happened in COVID was that the telemedicine came in, and that we leveraged that opportunity to start documenting the patient outcomes wherever we could decentralize, because we were already in the field at that time. We were already working for two years or so in many of the districts. And the moment we documented that the compliance improved and the outcomes improved, and started sharing these results more widely, we felt the acceptance of treatment at health wellness center has gone up. So it's really been a very complex, long journey. But I think the positive side is that I think if we stay on it and continue to demonstrate that the evidence is going in the right direction, I feel the stakeholders change their mind. That's all I can say. So it's not permanent. I think I'm going back to, I think, what Sumit also said, that we shouldn't think that today they think like that, so they will always think like that. So you people do change their mind when they see that things are changing. It requires a very prolonged, long-term commitment and hard work. Thank you.
Oh, thank you so much, Dr. Prabdeep. I was just listening to you. I have a few more questions, and then we'll go towards the closing round. Uh, uh, listening to you, it seems that one, this is, you cannot be in implementation research for the short term. This is a commitment that you make for the rest of your life, number one. Number two, just seeing you and how blissfully you were sharing the challenges. I believe that, it is a challenge absolutely worth embracing. I don't think this is something, if somebody were to, will not be able to make an offer to you where you'd like to say, well, we'll give you anything that you want, but you won't do implementation research. I believe that's an offer that you will never accept. So, am I correct?
Yes, no, I think it's addictive. Actually, when you make impact, you want to make more impact. So it's a feedback loop. Actually, initially, I mean, that's what you have to just stay on. I think that's the difficult part. And I find many people in the initial stages just get very demoralized. But if you stay on, and when you start seeing the impact, you will never want to give up on that.
Amazing.
I mean, it's the most satisfying thing you can do professionally.
And I think what you're alluding to is, I've always felt that, when you are doing a pure, particularly if you're a clinician and then you become a full-time clinical researcher, there's somewhere down in your heart that you miss out the gratification that you get, when you're serving a patient, making sure that there is an impact of your treatment. And I think that void in some ways is filled by implementation research. Because here, it's not just the evidence that you help produce, but you can see that actually impact at scale that is absolutely humongous. I'm just wondering, what you must be, if you tell your children that now when you go to a village and you find that somebody is actually taking those pills and making sure that, their blood pressure is in control, many would not believe that this was an impossible dream just a few years back. So I'm just, I can't see our other colleagues here, but I think that's what it is so endearing, so addictive about implementation research. It's so living. I think it's so transformative. I believe it's also something that we have, as a clinical researcher, when you start, I think that's something that we have to transcend. It's like dar ke aage jeet hai. It's I think this is, it reminds me of this, that, there is so much that you just have to believe and transcend that fear. And you all said you have gone through, but I can see that you're so, you want to relive that experience, time and again. I think it's also very transformative. I think on the evolution journey of research methods and researchers' life, I think implementation research also comes across to me as being on the frontiers of our evolution, where, you felt that they were simply subjects to them being collaborators, right? Where we can co-create a solution. We are no more just implementing, like it's almost like a dead, right? It's highly controlled. I do this, and it's very important as well. But when you take it here, it's such a living system, a system that appears to be complex. But I think when you start to use the field, listen and then act, and then listen and then act, I think that spiral tends to be, somebody was reminding me that, imagine that there is a water hyacinth and it tends to double, every day. And if you, by the 15th day, it has covered half that of a lake. How much more time will it take for it to fill the whole thing? And I was in a meeting yesterday and I asked, they said less than 15 days. Some of that said something else. Some said 12, some said 7. The answer is one more day. Okay. So I think one of the other message that emerges that it has a slow start, but once it starts picking up, and that's where you don't give up, right? you don't give up because it's just around the corner. And once you have turned the corner, there is no looking back. If that's what I hear. I'll go to Sumit. Sumit, you started where there was no even a drone policy, right? You just shared some of those. And now we are talking of organ transportation, right? Quickly, I'll just give you a minute and then I'll go to Pragati and other questions.
Yes, sir, absolutely. It is like addictive, ma'am said. We started with medicines, and then we thought it is impossible, and then we did vaccine, maintaining temperature, and then Bell sir came and he gave a next challenge. You have to fly at the 13,000 feet, which is quite impossible even for the army people. We went there, you were there seeing event, and we were there in 13,000 feet. We delivered vaccine, we pick up the samples, emergency medications, we implemented in Key and Lahore and Spiti. And then there was one more thing. Then he said minus 10 degree, minus 15 degree temperature. It was difficult for us to take a breath there, but we did it there. And then sir gave us a task. Sir said, I want to set up this thing as a secondary care hospital. You have to pick up sample from there and you have to deliver at tertiary care center. During the surgery, you will do reporting and you will report to the surgeon and surgeon will complete the surgery. And this was in just hearing it is so complex, but we did it during the surgery. We pick up the sample, we transferred it to tertiary care hospital. They did frozen section and histopathology. They reported to the surgeon and surgeon took the mastectomy and all the oncopathology they did. So, and it all happens in just 20-30 minutes. Usually it takes 3-4 days to transport. So all these now we are doing with the state health program, doing TB samples in tribal areas. And now, as you know, we are thinking about cornea, organs, kidney, renal. So yes, it is going on more and more challenging. Yes, sir.
Perfect. Thank you so much, Sumit. I think it's brilliant. I'll just have, we'll just come back to some very practical issues that Dr. Upendra actually he raised. And I think it's true, and every implementation researcher, faces this. And that's to do with the IRB. Right? And so, Dr. Upendra's question is, hold on, just let me, is doing IR in our context is that many ethics committees are yet to gear up to review and deal with IR, especially as iterations and evolutions are by design the part of IR, and some of the aspects, including stakeholder coordination, are difficult to, right? So quick response from Pragati and, just a quick response would be great. I know there's no easy answer, but.
Yes, thanks, Dr. Vishwajeet. There is really no easy answer. I think the more and more such studies come into the IRBs, and the more they get sensitized, the more discussions that revolve around it, chances are that the learning will increase. But from the side of the researchers, what they can do to help the process is to provide as much detail as they can in terms of like who are the stakeholders, what is the role that they anticipate, and not to leave too much to imagination or leave it fuzzy. So yeah, I think it's a two-way process from the committee as well as from the researchers. Yeah. It'll evolve.
And I think we also, I think as implementation research is picking up, and I believe it is time that, we need to do some more upstream engagement with the committee. And I think help them prepare. Most of them, I think, come from a paradigm. I think that needs to now move to a more improvised version. I think I believe it's also Dr. Upendra's, that I think besides, I think it's an excellent idea that I think it's good for us to build this community and speak to each other. But I think it's also important that, we need to take implementation research to implementers, right? Just the engagement, the dialogue, the policymakers, the administrators, so that they value it, so that they understand how useful it is. And I absolutely agree that we need to do that. And so, this is 7:30. Thanks to each one of our colleagues who attended this webinar. thank you to Dr. Kavita and the team at the National Institute of Epidemiology and the Indian Institute of Science who worked behind the scene to make it happen, both the technical team out there making sure that we are heard. And thank you, Dr. Prabdeep, just making the time. I know you were in a workshop, and thank you for coming. Thank you, Dr. Sumit. It was absolutely brilliant to have you and hear your story on the drone. So he's the drone man of our country. And, and Dr. Pragati, you're an absolute uh, champion. Thank you so much I know it was almost impossible, but you still cared. I know how much you care uh, you know, for this webinar. Thank you so much. This is absolutely extraordinary, and we remain very grateful. Over to Dr. Kavita.
Thank you. Thank you for
so
the
much.
opportunity. Yeah.
Thank you so much. It was like, wow, for me, so much of information within this, short duration. And I feel that it's not a everyday thing. You could, get to hear the little nuances of implementation research, which you don't get to read in the books. So much of practical tips that you people have shared. I hope it was helpful for all our participants. And I really feel very, impressed and very proud to be a part of this team. I was thinking when we started, no one was there to, tell all these small things. We have to learn by falling down and, getting up by ourselves. And one little thing I would like to mention here, we had one small, project in Sikkim. So when we went there, when we introduced ICMR, many people didn't know, in the beginning, but later we could, people say, ha, you're from IHCA team. But before there was a different ma'am. Then we tried to, piggyback on the previous ICMR team's experience. We were asking how you felt it was, easy, how you're doing that, easily, and why not our intervention. They were saying it is so simple. So context is important, and the intervention, it has to be in alignment with the community. We cannot introduce anything that is alien to the community. That is one point I wanted to mention here. And thank you so much for all the experts in the sense of experience, because the experience is very important here. So thank you so much once again for being part of this. And yes, sir.
Dr. Kavita, now before you leave, I just wanted to, for the coming webinar, I just realized when they have these heart and others, they look really good. So I would request all of them for the next session, please be generous with your hearts and your claps. It really looks very cool. Thank you so much.
Yeah, so talking about the next session, we will be listening from Dr. Ganesh Kumar about the study designs for IR research. So thank you everyone for attending the session. I think they followed your instruction very nicely. Thank you so much. So
no
till
instruction,
we meet,
is just so
yeah,
thankful
suggestions. Yeah. So our next session will be on 23rd October, 6 p.m. So till then, thank you and bye everyone. Thank you so much for attending.
Thank
Thank
you,
you.
Dr. Kavita.
Bye.
Thank you all.
Thank you so much.
Thank you.
Thank you so much.